All right. Hello, everybody. So just let me introduce Dr. Lynette Sholl briefly. So Lynette is Associate Professor of Pathology at the Brigham Women's Hospital and Harvard Medical School, and she's currently the Chief of Thoracic Pathology Service over there as well. So briefly about Lynette. So she obtained her medical degree from Stanford and then completed her residency at the Brigham. And she also completed her fellowships in thoracic pathology and molecular pathology in the Harvard system. So Lynette is a renowned expert in the fields of lung pathology and molecular diagnostics. She's had a very productive academic career. So I Googled her in PubMed. So far she's published more than 200 publications in the areas of lung pathology and molecular diagnostics. So I'm really happy that she's here today to give us a slide seminar, especially in this challenging time. So this is meant to be an interactive session. So especially for the residents, we really encourage the residents to participate. So because we have quite a few people here already, so just to avoid people talking at the same time, so if you want to speak or want to ask a question, please use the raise hand function in Zoom. So I can help pick out those people as we go. So I'll help Lynette moderate the session. So I think that's everything. So Lynette, why don't you get started?
Okay, sounds good. Thanks so much, Eleanor. And it's fun to be able to do this. I've been able to practice virtual teaching with our own residents quite a bit because obviously that's our only option these days. I will say that I usually use Microsoft Teams and I'm a little less facile with hosting within Zoom. So please forgive me if I make some stupid mistakes, or if you get more insight into my personal life than you wanted. You're sharing my screen. So anyway, you may see me getting interrupted by one of my 3 children, or you may hear my son, who's actually has a cello lesson going on remotely downstairs right now. So if you hear weird groaning noises in the background, you'll know what that is. In any case, this is, as advertised, a focus on neoplastic lung pathology. It's kind of a mix of the very kind of ordinary stuff that we see every single day that we just need to figure out how to manage appropriately, and some more slightly esoteric stuff, but that's kind of cool based on what we now know about the genomics of some of these lesions. So with that, we'll go ahead and get started. Eleanor did, as you heard, volunteer to help guide discussion. I would love to get some volunteers to go through these cases. And so if there's anybody who'd actually like to kind of kick it off from the beginning with the very first case that we had with a woman with a ground glass opacity, I'd love to take any volunteers. Anybody?
Anybody? Maybe we just go down the list. So let's see. Brian, are you available? Are you there?
Hey, I'm Brian. Yeah.
So do you want to try to describe the case?
Sure. Yeah.
Hi, Brian. Thank you.
Yeah. All right. So case number 1 here.
And if you want, this one we do have some radiology for. If you want, I can pop open the radiographic image if that's of interest.
Sure. Yeah. Let's take a look at that. Okay. Axial view. On the left side, there seems to be intraparenchymal area of interest. I guess that's the ground glass opacity that was referred to. Yeah. Not sure what else to say.
Yeah, you know, you can probably, it's not the highest resolution image in the world, but you can maybe infer that there's a little bit of emphysema. There's a little bit of increased maybe lucency in the lungs. So you know, probably we're dealing with somebody who's got a smoking history. But I think in this case, we did have a history of a patient who was getting getting examined by a low-dose screening CT protocol for because she qualified due to her smoking history.
Got it. All right. So what we see here on the digital slide, it looks like the section from the surgical specimen. Pretty good sized piece of tissue. Looks to be like lung tissue, and there's an area that stands out that's much more blue, and the lower left corner. Yeah, we go a little closer.
Yeah, I'm having a little bit of spasticity issue here. Sorry.
Yeah.
Slowly, here it comes. You want me to go any further, or is this good?
That's good. So there's, yeah, it's quite a bit more cellular in this area. There's some lymphoid aggregates, probably, some of those more dense areas. And then this does look like, it has the outlines of alveolar lung parenchyma, but I think if we look closely at the cells lining the alveolar spaces, they appear to be, cells that are much more prominent than what you might think of as normal type 1 pneumocytes, I guess. And then the interstitial space is somewhat expanded and also fairly cellular. Yeah, some of these areas also, there's some cells that are kind of sloughed into the alveolar space as well.
So what's your differential diagnosis?
I'd have to include like an adenocarcinoma, lung adenocarcinoma. Mm-hmm. There are maybe some benign entities to consider too, probably number one would be a lung adenocarcinoma.
And then on that spectrum of adenocarcinoma genesis, if you will, in the lung, what are the entities that kind of bridge that spectrum from kind of the earliest lesion to kind of a full-blown case of
Sure. I think probably maybe the earliest might be, I think it's called AAH. Is that right?
Mm-hmm.
Atypical adenomatous hyperplasia.
Right, yeah.
I don't think I've ever seen one of those before, but they should be really small, right?
There's a kind of a rough size criteria, which is less than 5 millimeters. It's not a strictly enforced criteria, but in general, if it's a lesion that's fairly discrete, has low-grade cytology, and usually it's barely visible, and typically you can't see them by radiology, although it kind of depends on the study that you look at. But that would qualify as an AAH.
Yeah, and I'm actually a little fuzzy on what we nowadays we call like adenocarcinoma in situ versus invasive adenocarcinoma, or just adenocarcinoma with the pitic type. I think there are some size cutoffs too, and to me it always seems kind of like weird and arbitrary.
Well, you know what? You're not the only one. I think we're all a little fuzzy on exactly what the definitions are or should be, or even when the definitions are kind of clearly numerically laid out, there's a lot of controversy over what defines really the different steps of tumorigenesis in this space. So as you pointed out, AAH is the earliest lesion and thought to be kind of the clonal precursor of adenocarcinomas, at least those that arise out in the lung parenchyma. The next would be adenocarcinoma in situ, and that's defined as any purely lipidic growth pattern, lung adeno that's 3 centimeters or less in greatest dimension. And that's kind of an arbitrary cut point. It's like, what do you do if you have an adenocarcinoma in situ that's greater than 3 centimeters? Fortunately, they're exceptionally rare. It's pretty unusual to have something that big that doesn't have some component of invasion. So there's really no data on how to classify those appropriately. I think, you know, if you have something that's, say, 4 centimeters and almost all lipidic, it's probably best to classify it just as an adenocarcinoma. It's a little bit difficult to know exactly how to stage it, so it probably requires a long note. But we won't get into too much detail with that because it's a pretty unusual scenario. For lesions that are, again, 3 centimeters or less and have no more than 5 millimeters of invasion, that would be a minimally invasive adenocarcinoma. And then finally, anything that has 5 millimeters or more of invasion would be an invasive adenocarcinoma. And as you pointed out, we would describe the dominant growth pattern. For instance, it could be a lipidic predominant lesion if, say, it's 3 centimeters in size and there's only 5 millimeters of invasion. That would be a T1A lipidic predominant invasive adenocarcinoma. And so I wanted to just bring this up because I do think that the criteria for calling these different lesions is challenging. There's a lot of confusion, I think, on the clinical side in our terminology. You know, what is an adenocarcinoma in situ versus what is a minimally invasive lesion? What we do know from survival analyses from the last few years after the IASLC and the WHO really proposed these criteria are that the survival outcomes for patients who have who have adenocarcinoma in situ versus minimally invasive adenocarcinoma are virtually identical. So there's not a lot of risk to kind of making a mistake between calling something an AIS versus an MIA. And in general, the surgeons, at least in our practice, will typically proceed with more conservative approaches to lung surgery. So they may do more lung conserving wedge resections or segmentectomies as opposed to full lobectomies if you call something an AIS or an MIA, especially on the frozen, which is a challenging exercise in and of itself. Whereas they'll typically do a lobectomy and be sure to get a good lymph node dissection if you're confident that you're dealing with an invasive adenocarcinoma. So there's a lot of debate over exactly what defines invasion. So just to kind of complicate things further, what is pure lipidic growth versus what is minimally invasive growth? And this would be a lesion, I think, that we would probably have a fair amount of disagreement about. This lesion, I think we may have ultimately signed it out of as an adenocarcinoma in situ, but we could very well be wrong. The challenge, I think, is that there's not really any gold standard for defining invasion in this context, especially when you're looking at patients who are cured surgically. There's not really a way to distinguish between those two entities based on outcomes because you virtually see no differences in outcomes between AIS and MIA. But you know, you can look at an area like this and say, well, maybe this is more acinar growth pattern, and this is evidence of glands infiltrating through pre-existing fibrous tissue, so therefore this is invasion. Or conversely, you can say, well, maybe this is just an area of a little bit of excess stroma and stromal collapse, and everything is compressed and therefore looks invasive. And there's actually a fair amount of variability in terms of interpretation of these growth patterns just based on where you practice. So if you practice in the US, you tend to be more invasive, you tend to be more malignant, because that's the global perspective. Whereas in general, people who practice in Europe tend to be maybe a little bit less prone to calling things invasive. A lot of pathologists in Asia, particularly in Japan, feel more comfortable making that call if they have the benefit of an elastic stain to define the underlying architecture. We generally don't use an elastic stain, but there certainly are pathologists in the US who will rely on that as well. So, you know, the bottom line is, you know, AIS, MIA is a bit of a difficult distinction. MIA to invasive adenocarcinoma, there's a bit more of kind of tension there, or a little bit more hanging in the balance in terms of how they might manage the patient if you do want to kind of make the call of an invasive adenocarcinoma. So it does matter what we call these sort of areas of putative invasion, but in general, something that has very low-grade cytology like this, where you're kind of struggling to define whether it's invasive or not. I tend to be a little bit more benign. I tend to try to sort of err on the side of calling more of this in situ growth rather than frank invasive growth. Of course, I think I've got several pulmonary pathologists on the line as well. If anybody else has any opinions that they want to share about dealing with these types of lesions, I'd certainly love to hear them. But if not, we can move on to the next case. Does that sound good? Everybody happy?
Yeah.
All right, excellent. Brian, thank you very much for your description. You did a great job.
Can I say
yes.
something?
Yes, hi.
Hey, how are you?
Good, how are you?
Good. Yeah, this lesion actually 2012, actually 25 international pathologists involved this kind of lesion about focal invasion or not.
Yep.
Kind of only 50% kind of concordant.
Yeah, it was very impressive.
Right. I have another kind of related procedure question in pregnant women. Do they often do need a core biopsy, then do wedge it like?
Yeah, and you know, we don't have enough time, I think, to go into all of the potential pitfalls of say making one of these diagnoses on a core needle biopsy. We certainly will, in some cases, see these patients get a core needle first. You know, I think it depends a bit on where they present initially. Many of our surgeons may take them directly to the operating room as opposed to getting the core needle biopsy first. It depends who they may talk to initially. It depends a bit on the patient preference as well. But these, I think, are incredibly challenging lesions to call with confidence on a core biopsy. I think that the risk of overcalling something like this, or overcalling a reactive proliferation, and adenocarcinoma in situ is quite high on lesions like this. So these always make me super nervous.
Right. So also because we always are asked to like examine the gross examination, the issue here sometimes we could not find truly, even surgeons could not do it.
Yep.
It's something trouble actually.
Yeah. Yeah, these are you know, they're a special problem on many levels. You know, our surgeons have taken a couple of approaches, including using fiducials that they place preoperatively with the assistance of CT imaging in order to localize the tumor. That's a little bit more in the protocol space. I'd say most of them tend to just, you know, go with the CT localization that they have from the preoperative CT, and then they whack out a piece of lung and they stick a stitch on it and they send it out to us, and usually the stitch is 7 centimeters away from where the lesion was. So we spend a fair amount of time on that specimen trying to find it. But it's a very challenging issue in the frozen room. I would say that, you know, looking at the radiology, I find it to be incredibly helpful. You get a sense of how large it is, the distance from the pleura, the distance from any large airways, helps you to localize it when you're looking at that gross specimen, gives you a sense of you know, just how subtle is this thing going to be, and what is the likelihood that they just miss the lesion entirely when you're looking at it.
Okay, thank you.
I would say these are really, I think, very difficult lesions, and you know, really requires kind of the whole team to be present and really kind of looking at that specimen and make sure you've got what you need. Okay, so I'm going to move on to the next case, case number 2. Do I have any volunteers from the residents to review this one?
I don't see anybody raising their hand, so I'm just going to pick one of them again. So I see David. David Wells, are you there?
Yeah, I'm here.
Yeah,
Hold on. Let me switch my my speaker.
Okay.
Okay. Can you guys hear me okay?
Yeah, you're nice and clear.
Okay. So here we have, or let's go over to the radiology first.
Yeah, you know, I think this one maybe we didn't have radiology on. This one we just have a bit of history. He's 64, about a 2.5 centimeter spiculated mass, as well as mediastinal lymphadenopathy.
Okay. So we have what looks like lung parenchyma. It's not the most well preserved outside of the central mass, but as I said, there is kind of a central area that's.
Can I just ask you to pause for a second? Can you tell, what do you mean by not well preserved?
I suppose like we don't have, you can see some areas where there's nice open alveoli, but there's also a lot of pink. And at this power, it's unclear, you know, is that just collapsed lung or is that fibrosis surrounding this thing?
I'm going to press on this a little bit further because I think it's important for kind of contextualizing the lesion. Let's just zoom in a bit into the background lung and maybe talk about it a little bit more. And sorry, I know this is a neoplastic talk, but there's so much to learn from the background lung.
Yeah, so the background lung, I mean, some of the alveolar spaces look a little bit more open. It makes me think possibly there's some emphysema going on. Wonder if this guy could be a smoker. And can we go a little bit higher power?
Yeah, of course. We'll kind of like catch both of these areas at once. What do you think about this stuff here? All this sort of like grungy brown stuff.
I mean, it looks like it could be just anthracotic pigment in macrophages. And it looks like the macrophages are within the alveolar spaces, which might be giving it that more cellular look. But the pneumocytes around here look fine in this particular field.
So the one thing I would just say is he definitely has some emphysema. He's got this sort of funny pattern, you know, maybe he's got a little bit of like mosaicism where there's some areas that are better inflated and others that are more collapsed, which may be artifactual. He could have some component of like chronic bronchitis or something that's maybe contributing to this. But, you know, the thing about his emphysema is that he also has a component of fibrosis with it. And then, you know, these sort of pigmented cells, these are all macrophages in those air spaces, right? And this pigment it's a bit of a mixed pigment. I think there's some chunkier stuff in here and there's some like darker kind of anthracotic stuff. I bet there's a fair amount of smoker's pigment in these macrophages as well. So it's kind of what we call respiratory bronchiolitis. And there are some pulmonary pathologists who would say, well, you have a combination of what we call of emphysema. You have this sort of bland hyalinized pulmonary fibrosis, and then you have all of these smokers macrophages or respiratory bronchiolitis. That kind of triumvirate is sometimes referred to as smoking-related interstitial fibrosis, which is really something we only see in patients who have a very substantial smoking history. So even though I don't tell you in the history, this guy has about an 80-pack year smoking history, and his lungs actually kind of tell us that because they're actually very damaged in a pattern that's quite characteristic of long-term smoke exposure. So that'll be a little bit of additional clinical hint in this particular case. And I'll hand the floor back to you, David. Sorry.
No worries. That was great. So I guess at this point we can go over to the more cellular looking mass. Wherever that is. There we go. So it's
zoom in, or are you good?
At this point, I mean, it's fairly well circumscribed in the sense that, you know, it's this kind of single area. At this point, yeah, let's go in. It's fairly blue.
Indeed it is.
And then just things I'm noticing at this power, there's not a whole lot of gland formation. It looks pretty sheet-like, other than that area on the left over there.
Yeah.
And then go in a little bit further. So it looks, certainly looks like there's a little focus of necrosis there. But otherwise, it's fairly sheet-like, filled with these quite atypical cells that have this almost rhabdoid appearance with that kind of pushed aside nucleus and that eosinophilic cytoplasm.
Yeah.
Not forming any particular structures that we're seeing.
Yep. Agree. So what do you want to do with this case?
Oh.
You want to do any immunohistochemistry?
I'm just trying to think what immunohistochemistry, what would I want it to tell me? So, I mean, certainly we have that area over there that's actually glandular and would be consistent with the pulmonary adenocarcinoma off to the left.
Although you could argue it has a kind of a funny, almost columnar growth pattern that has this sort of vaguely enteric look to it. You could ask, is this like a metastatic colon cancer or something that has almost like a medullary component or something? It's sort of hideous sort of solid, and then there's this more glandular component. I think it's unlikely, but you just sort of wonder. It's kind of a funny looking thing.
Yeah. Otherwise, I mean, so if I did a TTF1, if it were positive, it would just tell me what I already suspect, which is this is lung. And I wouldn't be surprised if that particular area lost TTF1, the more rhabdoid looking stuff. It doesn't really strike me as small cell, but it's not a bad idea to just do a synapto and chromo throw one there.
Sounds good. I think that's a very prudent approach. I tend to agree with you in terms of a somewhat minimalist, consideration of immunohistochemistry. You have somebody who has a serious smoking history and what looks like a primary lung cancer radiographically and clinically. I agree. There's probably not a huge reason to do a lot of immunohistochemistry if you have obvious kind of gland formation. I would say this thing is a little funny looking though, and so you do sort of ask, is this a collision tumor? Like, is there any possibility these could actually be two different tumors? Or, is there anything about this thing that's kind of special that, because it is such a weird looking tumor that we should, think about? What we have recognized of late is that tumors that have rhabdoid morphology pretty consistently, and I can't remember exactly what the numbers are. I would say probably 20% of the time or thereabouts actually have SMARCA4 loss of function. And everybody's all fired up about SWE/SNF pathway stuff right now. So given that, and also given the fact that there's actually recently, if you count 5 years ago as recently described entity of SMARCA4 deficient thoracic sarcomas that was described by a French group based on transcription profiling efforts, you could sort of look at this and be like, well, it looks kind of like the tumors that they described in that particular series, but at the same time, it also looks like this thing just has an adenocarcinoma component in it. So what is this thing exactly? I'll just quickly show you some immunohistochemistry. So here's just a screenshot of his, let's get rid of that. There's a screenshot of his H&E. So there's a CAM5.2 just to demonstrate that both components are keratin expressing, although the glandular component has much stronger cytokeratin 7 expression, sort of throws out that idea of this being an enteric type of tumor. As TTF was performed, it was actually positive in the glandular component, and maybe there were 3 cells that were positive in the poorly differentiated component, just as you had anticipated, David. And then here's the SMARCA4. So indeed, this is a tumor. Now keep in mind, this is a tumor suppressor gene, and we expect it to be expressed kind of at basal levels, and obviously died as well. In the interest of time, we'll just conclude our discussion of that case. It is indeed a SMARCA4 deficient lung adenocarcinoma. There's actually some debate about how to actually phrase the diagnosis for these lesions right now, because there is this sort of concept of whether there's a sort of thoracic sarcoma that is SMARCA4 driven based on these expression profiling studies. But I think many of us sort of see consistently these situations where we have what's obviously a lung adenocarcinoma that gives rise to a more dedifferentiated component. SMARCA4 is probably a relatively early hit in these lesions. Why does it matter clinically? I think we're still figuring that out. There's a lot of folks who are very interested in the impact of SWE/SNF pathway alterations and a response to immunotherapy. I don't think there's enough data yet to know whether SMARCA4 loss actually predicts a better or worse outcome following immunotherapy. There's a lot of confounders in those comparisons right now, but anyway, I think there'll be more, more certainly in the literature around this moving forward. So let me just make sure I'm able to see the participants quickly. There we go. Okay. And then we'll go on to our next case. Yeah.
Quick question. Supposing you can't assess for SMARCA4, how would you categorize it?
Yeah. Then in this case, I think the top line is, it's a good question. You could probably, it's a good question. I have to see what the thinking is in the current WHO draft that's going around now. So I think honestly, this would be a solid predominant lung adenocarcinoma, and I would emphasize the fact that there are rhabdoid features. Rhabdoid tumors in and of themselves are not considered a separate entity. I suspect there might be some folks who say there's enough kind of pleomorphism in this really poorly differentiated component that some people might call it a pleomorphic carcinoma, but I would probably stick with solid predominant lung adeno.
And just for curiosity, does the poorly differentiated component expressed by Menton also?
It's a good question.
Lots of rhabdoid
I'm not
tumors
sure.
do,
I'd have to go back and look at the studies.
Okay.
We don't routinely run Vimentin.
Yeah.
Okay, so moving on to the next case. Anybody want to volunteer to tackle? This is actually it's a two-parter, 3A and 3B. If I can get this guy to open. There we go.
Sure, I can do it.
Great. Thank you, James.
Yeah, no problem. So low power view here, we have a well-demarcated mass in the center of this apparent lung resection. Very blue, very cellular at low power, some kind of hemorrhage associated with it, and perhaps another additional portion of mass in the left-hand field, a smaller bit adjacent to what appears to be a bronchial space or something like that.
I think that's probably just node. I think it's yeah, I think that's definitely something from low power. It's hard to assess.
Yep, just lymph node. Okay.
Did you want to zoom into this one higher power?
Sure, if we can see the main mass. It's still refreshing on my screen. Okay. As we get closer here, we see a very cellular neoplastic population here, presumably. It has somewhat of a kind of, well, it's overall, I would describe it as pretty solid growth, but some areas it gives you an impression of kind of spindling, perhaps some kind of fascicular growth pattern. It looks like there's actually a decent amount of cytoplasm associated with these nuclei, but overall this looks pretty darn monotonous to me.
Yeah.
Maybe we can go in a little closer just to assess the nuclear detail.
That may be, unfortunately, that may be about the max of our resolution.
Okay,
right?
yeah, just refresh for me. Okay,
Okay,
cool. Yeah, so we kind of have this mixed kind of clumpy chromatin here. Perhaps a salt and pepper appearance. Looking at this, I'd be concerned for neuroendocrine potential neoplasm here.
Yeah, sure. Okay, so that's on your differential. What do you want to do to prove that?
IHC would probably be helpful. So snapstone chromo.
Yeah, and so exactly, they're both very positive in this case. So how would you classify this then?
So going from there, I think
I should back up. What would you do to classify this correctly?
So we should grade it. So we'll need to look through for mitotic activity.
Absolutely. Well, we won't do that right now.
Thank you.
To say that it was actually fewer than 1 per 2 millimeters squared.
Okay, so that'd be a low grade, so like a carcinoid.
Correct. And in the lung space, our terminology is a little bit different in lung than say in the GI tract. What are the kind of flavors of carcinoid that we talk about in the lung?
flavors. So there's typical, atypical, and then
Exactly.
the high grade.
Yeah,
Small cell.
yeah. So this would be a typical carcinoid. So that's not very interesting, right? It's not a very interesting diagnosis. Kind of a dime a dozen in pulmonary practice. This case was interesting though for two reasons, and what I'll start with the first reason, and then we'll move into kind of the background log and slide 3B. This, as you can see from the low power image here, this was very much a central lesion. It's obviously compressing on a large cartilaginous airway. It was biopsied on an endobronchial approach, and a very small specimen was obtained, and it was quite crushed and very cellular looking. And for one reason or another, it went through a bunch of different specialists, and ultimately it was called poorly differentiated synovial sarcoma.
Oh, geez.
So it was a bit of a surprise when the specimen was resected and turned out to be a carcinoid on surgical pathology. So there was that one sort of interesting pitfall that can happen. We've had more than a few scenarios where carcinoid tumors are indeed confused with higher grade sarcomas one way or the other. My screen is getting dark here. And then if we go on to onto slide 3B, there's something else that's kind of interesting about this case in the background. And James, do you want to talk about this part too?
Sure. It's still refreshing for me, so be just a second, I guess. Well, currently I still have the 3A case up. I don't know if it's still coming up.
Yeah, it's not changing on my screen either.
Oh no, I hope this is not a disconnect again.
So she disconnected again?
Yeah.
Oh no. What's happening today? Okay.
At least it sounds like our theory of the disconnected modem was
Oh, yeah.
highly fixable problem.
Yeah.
Yeah, actually, I want to ask her a question about if like mitotic activity, if more than 10 per 2 square feet, right? So based on current WHO, this is supposed to push to larger cell carcinoma, really, if like 11, 12, right? So if you read the 2015 WHO classification, just based on mitosis, neuroendocrine morphology, like a carcinoid tumor.
You said less than 1, right?
This is less one, but I mean, the WHO, sometimes we have a kind of case like a more than 10, put like a 10 high power fields, right? So, but still morphology like carcinoid, then WHO recommended you have to classify this kind of larger cell carcinoma. Sometimes I don't feel comfortable.
Seems crazy.
Oh, she's back.
Hi guys, we're having a lot of internet problems here. I'm really sorry.
Oh, no worries.
Not typical, but evidently this was not a good day to do this. Can you hear me now?
Yeah, yes.
Okay. Now let me see if I can get Path Presenter functioning again. All right, we're back in business. This is crazy. I'm really sorry. And I heard some interesting conversation about carcinoids versus large cell neoplasms going on in the background. Oh yeah.
Yeah, Hado, maybe you can ask that question again.
Yeah, please do.
He's probably not there. Is he there? Anyway, he's probably muted.
I'm back, yeah.
Yeah,
So,
can you ask your question?
WHO recommended say if you have a carcinoid morphology more than 11, more than 10, right? Let's say 11, 12,
Yeah.
how to classify, but the cell-based classification will be WHO, the large-cell carcinoma.
Yeah, it's a challenging space right now. You know, and it's funny, if you talk to some of the folks who were involved with some of the original classifications, there was actually a debate at the time about whether the cut point should be 20 mitoses or 10. And I think somewhat arbitrarily or based on statistical modeling, they decided to go with 10. And obviously a lot of us have sort of pushed back on that because, as you said, you can have something that looks exactly like an atypical carcinoid, but that has 11 mitoses, and then you're calling that a large cell neuroendocrine carcinoma. And what we've done in looking at the genomics of some of those is demonstrated that they look just like, carcinoids from a genomic standpoint. So I think we may see some migration in those categorizations, but I don't think it's going to happen for the upcoming edition of the WHO. We probably need a little bit more information about it. It's fairly unusual scenario, right? It's not very common that we get those cases that kind of fall in between.
We had a couple actually. Then medical oncologist say, "How do you treat the patient?"
Yeah, it's a great question.
Right.
Yeah, it starts with how do you even describe them accurately so that they know they're not dealing with a large cell neuroendocrine carcinoma with 80 mitoses versus one with 11. And we'll typically I try to apply the WHO criteria, because I want to stick with what the book says I should do. So at least I'm consistent with other practitioners, but I will qualify it in a note and say, even though this meets a criteria for large cell neuroendocrine carcinoma, it morphologically resembles an atypical carcinoid, and just some food for thought for you. And they don't really know how to manage these patients optimally right now. Hey James, did you want to take over looking at this part 3B?
Sure, we can do that. So again, looks like piece of lung resection. We have similar hyperchromatic cellular nodules here. Looks like a couple of them within this tissue. And as we get to higher power, it looks very similar to what we had previously seen.
Absolutely.
I would go so far as to say virtually identical.
Yeah, absolutely.
So presumably in this context, we then would have to figure out whether we thought that this was metastatic disease from the main mass, or if this is an isolated like tumorlet or a neuroendocrine hyperplasia kind of scenario. Yeah. So as we looked around the lung in this case, we actually saw numerous areas of what I'm showing here: neuroendocrine cell hyperplasia there underneath the airway, as well as those tumors kind of busting out through that basement membrane and forming little nodules around those areas. So all of these things that we just looked at, they were all less than 5 millimeters, so they don't be classified as tumorlets, carcinoid tumorlets. But given that we have this really pronounced sort of hyperplasia component in a lot of these, it fits really with more of a background hyperplasia pattern that's then evolving to these sort of independent tumors. So it looks like it's probably not metastatic disease, but obviously something you need to exclude, kind of morphologically. Now, given that we think there's probably a background of hyperplasia, of this neuroendocrine cell hyperplasia, do you know what we would call this potentially, assuming that the clinical radiographic picture sort of fits? I recall that there's a term for multiple carcinoid tumorlets. I don't recall the precise term.
Yeah, no worries. So the quick term is DIPNIC, which stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It's another somewhat controversial topic because we don't really have great set criteria for making the diagnosis. It really is a multidisciplinary diagnosis. And the other challenge is oftentimes when you have a carcinoid tumor, you can have some associated neuroendocrine cell hyperplasia, or maybe what look like little tumorlets right around the area of the carcinoid. And I think you have to discriminate that kind of local change from something that potentially is affecting the lungs bilaterally and that ultimately could have more significant physiologic consequences. The concern if people have this process of this idiopathic diffuse neuroendocrine cell hyperplasia is that, as you can see, these cells will proliferate here under the airways and actually can lead to fibrosis around the terminal airways as well as collapse of these airways. So you can see patients who will actually present with changes in their pulmonary function as a result of this process. The radiologists are often fairly good at correlating based on CT scans as well. So they will have a relatively high level of suspicion if they have a patient who has a known carcinoid and has multiple, often sub-centimeter or sub-5 millimeter nodules in the background lung. Our surgeons are very excited about this diagnosis for reasons that are not entirely clear to me, but it seems like the more excited they get about it, the more cases we tend to see. So, so you don't see a lot of it, but it's definitely something that's on the clinician's radar. Any questions about that case? Okay, if not, you guys can hear me?
Yes.
Yes.
Okay, great. If not, let's move on to the next case, case number 4. Does anybody want to tackle this one?
I'll just pick someone. Who is it? Is it Marie? Marie, do you want to describe this one?
And I think we have radiology on this one. Let's see.
Oh, she responded she does not have a mic because she's at
Oh, okay,
Harvard.
that's a problem.
So what about,
We can do this one. We
okay,
can go.
sounds good.
Okay, so is your name Thomas?
Yeah.
Hi, thank you.
Yeah, you're welcome.
This was a middle-aged lady who has multiple, and she had this lady I think had a history of, oh, let me see. This is our lady with a history of breast cancer, and now she's got innumerable bilateral lung nodules. And here's our radiology. Can you see the film?
Yes, yeah.
Okay.
So there's a lot of little round nodules kind of spread throughout both lungs.
Yeah, and I think, you know, that one of the challenges, I think, and I'm no radiologist, but I think one of the challenges is discriminating between pathologic nodules from just cut sections of vessels and airways. This one sort of stands out. It's easier to tell as you scroll up and down through these axial images, but you can go through lesions like this and sort of see that they're spherical when you actually scroll through. And as you look around, you can see that there's quite a large number of these. Even these little guys out here are part of this disease process. Okay, so based on that radiology imaging, we got a biopsy. What do you think that their differential diagnosis was based on the radiology?
Metastasis, and then if there was anything else clinically going on, I mean, diffuse nodules could be an infection.
Yeah, absolutely.
So, yeah.
Okay, so here's our wedge resection in this case.
And you can see pretty discrete nodules. They look very pink and not extremely cellular, so it's a little bit puzzling. And then there's a prominent dot sign on one of the larger
Which
nodules.
I meant to erase and I didn't manage to do it in time. I'm actually not sure what it shows, so I think that maybe we should not spend a lot of time with the dot sign, but we'll go into higher power.
Good. Yeah, sounds good. And the lung looks fine. There's, yeah.
I agree.
There's not a lot of background changes. So it looks very pink still. I'm not getting a great look at the cells, but kind of has a almost zonal look with some central loss of nuclei, I think. So, and then the general pinkness and the types of cells I'm seeing makes me think of a granuloma.
Yeah.
It's, you know, kind of forming solid sheets of epithelioid, possibly histiocytes, cell lesion, but I think that it looks more like a granuloma, especially with that sort of central necrosis type stuff.
Yeah.
Or colonization.
So I can tell you that this case was signed out as granulomatous inflammation when it was originally reviewed. And then it was actually re-reviewed and the diagnosis was changed to a neoplastic process. So there's a bit more time spent thinking about these cells that are entrapped in this sort of dense pink matrix. You want to describe these cells a bit?
Well, there's some really epithelioid round cells that are sort of mostly single filing around. The fact that they have eccentric round nuclei that are somewhat low grade, and the patient has a history of breast cancer makes me think of lobular carcinoma a little bit.
Yeah, sure.
That could be just involving a, well, causing some sort of fibrotic reaction that's mimicking a granuloma. Not sure what else.
Okay,
but
so
it was a bit weird for that.
yeah, so I can tell you that a keratin stain was negative in this case. Any other stains you'd like to try? Any other lineages?
Maybe an S100.
S100's negative. And the resolution's a little hard to see here, but it's doing this kind of weird thing, right? Where you see this like pink material inside of a kind of almost a lumen that's forming. Like the nuclei are kind of off on the side, and then there's like a little bit of an open space, and in some of these open spaces, you see a bit of this sort of pink material, or almost like a pink cell. I'll give you a hint at all. If you've never seen one of these and haven't thought about it, you'll never think of it. But it is something that we see in the lung that's actually native, kind of a native tumor to the lung in some instances. Here's one of these kind of cell, tumor cell with a cell inside. Yeah, and the fact that there's something that I've seen that I can't take back, but I think that now I know what those are, and they are little vascular lumens, which I've seen before. Yeah, actually in the middle of the dot, there was something that looked quite a bit like a yeast when I previewed it, so I was totally going down that way. Yeah. But I think that it is probably an epithelioid hemangioendothelioma. Yeah, you got it. So that's exactly what this is. It really interesting tumor, and interesting kind of from the clinical standpoint as well, and radiographically, obviously really striking radiographic pitfall for metastatic disease, especially in a patient who has a breast cancer history like this. These patients who have epithelioid hemangioendothelioma these tumors can behave quite variably. Patients who present like this with very small nodules often can have very indolent disease. And this patient actually was originally diagnosed in 2014. She's still being followed at our hospital. So now we're 6 years later, and these have changed only very minimally. There's been a little bit of growth, but very little. So they're just following her radiographically, and they don't intend to make any sort of therapeutic interventions in her case. There are other patients who can have very substantial burden of disease, and in particular, the tumors that tend to invade the pleura tend to be more aggressive and lead to death. But the ones that appear to be kind of confined to the parenchyma tend to have a very indolent behavior. So a few times I've talked to surgeons about this diagnosis, and knowing that it's a relatively unusual diagnosis, I'll say you might want to at least have the patient seen by the sarcoma clinic, because they tend to handle our kind of endothelial tumors. And at least one of the surgeons she'll live forever with this particular diagnosis. So they clearly sort of see the patients, I think, who tend to do a little bit better, and maybe managing those folks in the outpatient setting. So do you know anything about the genomics of this lesion? Not off the top. I think we've broken up a little bit. Can you hear me?
Yeah, we can hear you.
Okay. Sorry, go ahead, Eleanor. I should ask you, huh? You know more about it than I do.
Yeah, this should have the do you usually fish this, or you just make the diagnosis based on
We
based
have a
on
really
biology?
nice IHC on these now that we tend to rely on. We typically don't do fish.
Okay. Because this file will have the CAMTA translocation, right?
Yeah, and this one did, and we use the CAMTA1 IHC antibody when we see these. It's not obviously not 100% sensitive, but it's pretty good. And when you do get a nice positive result, then we're usually done.
And it looks like there are 2 nodules in this
Yeah.
case, right? So
Yeah.
it's just multicentric, like 2 independent.
Yeah, it's a great question. Eleanor, I don't know. I assume that it's all interrelated. I don't know how these things connect to each other, right? I really have I don't have a great sense of what clonality is in these cases. Obviously, she's got lesions on both sides, and so there had to be a way for it to get to both sides. Presumably, it spread intravascularly and just has a relatively indolent behavior, despite its ability to kind of move around in the lung. But I don't know. It's pretty fascinating, actually, and what sort of like flips the switch from it being, all over the place in the lung but growing very slowly to becoming really aggressive and ultimately potentially even leading to more systemic disease is I think not entirely clear.
Yeah, I had a case like a liver has kind of like a hemangioendothelioma. Lung had lung bilateral. At that time, nobody knows this meds or de novo.
Yeah. Okay. All right. Let's go on to the next case, case 5. Anybody want to tackle this one? This one, I think I can't remember if we have radiology or not. We do not. She's got a solitary 1.5 centimeter right lung nodule, incidentally detected.
I can do this one.
Great.
Hi. So we see a well-demarcated nodule that looks pretty blue and has really dilated looking vessels filled with blood at this power.
Mm-hmm.
If we go a little bit higher power, we see it's pretty cellular. And there's some glands I see in this power that are lined by columnar looking cells. And there's also a pretty cellular stromal component. I guess from this power, I could kind of hallucinate 2 cell types here.
I agree.
One is the cells lining the glandular spaces that look more eosinophilic to me and columnar, and the other component looks more like it has a lighter colored cytoplasm, although both components look fairly not that atypical. So it being kind of a well-demarcated lesion and this 2 cell component makes me think of a sclerosing pneumocytoma, or what used to be called sclerosing hemangioma.
Yeah, perfect.
So I would do stains with TTF and a keratin to highlight these 2 populations.
And what do those markers show?
So I believe if you did an AU13, it would highlight the component lining the glandular spaces, and then it would be negative for TTF. But then the TTF would highlight the stromal cells, but not the stromal cells would be negative for the keratin.
Yeah, I think the TTF typically will pick up both components. The stroma definitely has really the stromal cells have markedly diminished keratins usually. You could do both a keratin and an EMA, and both of those would really nicely highlight that surface population and tend to be quite low in the stromal component. But that was a really terrific description, and I think you can probably infer why it was maybe called sclerosing hemangioma, which was really back in the days before we had immunohistochemistry, because these tumors pretty typically have this very striking capacity for forming these big dilated spaces that tend to fill with blood. And so the assumption initially was that this was more of an endothelial type of lesion and not a pneumocyte or at least a TTF1 positive type of lesion. The genomics of these is actually increasingly understood. Lisa, do you have any idea of what the underlying genetics of these lesions is?
No.
Yeah, so it's all relatively new. We've known now for maybe 2 years or so that at least half of these sclerosing pneumocytomas will have AKT1 hotspot mutations. So the codon 17 hotspot is recurrently mutated without a whole lot else, which is probably not surprising, right? We get a bit of an oncogenic kick from a mutation in AKT1, but we typically don't see a lot of tumor suppressor gene alterations. The cell cycle looks like it's relatively intact. It's just kind of accelerated a bit because of that oncogene. And then the question was, what was going on with the other half of sclerosing pneumocytomas? Do they have another type of oncogenic mutation? It turns out that the other half actually also have AKT1 mutations, but they're slightly different. They're larger in-frame deletion, insertion deletion mutations. So they're a little harder to pick up using standard say amplicon sequencing based next-gen sequencing or many of the assays that have been used to study these up until last year. So a group from Taiwan published a pretty comprehensive analysis of these and showed that about, again, half the time they've got these AKT1 point mutations, the other half of the time they have these AKT1 insertion deletion in-frame mutations that are also activating. So they're kind of interesting. They're a little bit, you can think of it maybe almost a little bit like a nevus that maybe has a BRAF mutation, but it doesn't have enough oomph to kind of lead to metastases. These are kind of the same way. They clearly have an oncogenic driver, but they typically don't metastasize. Patients who have these lesions, once they have them resected, they virtually never recur. There have been some patients who will have these lesions follow, then they tend not to grow significantly or, again, to metastasize. There are a few case reports out there of these metastasizing, but it's a pretty unusual scenario. But they're kind of cute lesions. The kind of senescence pathway or senescence program lesion of the lung, if you will. Any questions about those from the group? Okay, well, thank you, Lisa, for your very nice discussion. Let's go on to case number 7. Anybody want to describe this case? And we've got some radiology on this one.
I don't see anybody raising hands, so I'm just gonna pick on somebody again. Let's see. We don't have that many residents left.
Oh,
let me see.
Sorry. The technical difficulties are not helping the situation.
Let me see who's here. Oh, Isaac. Isaac, can you hear us?
Yeah, I can hear you. I had to use my phone though, because my internet.
Very clear. You sound great.
Okay, but can you see the screen or no?
I can. It's just really tiny.
Okay.
Oh, no.
So with that caveat, I'll do
okay.
the best I can.
Okay.
You'll get extra points if you can describe it on your phone.
I know.
Okay. Okay. Well, radiographically, there's some diffuse hyper-intense lesions and bilaterally. Oh, and in the peripheral.
Yeah. And then anything else about the lungs that you want to comment on your phone?
I mean, look, I don't know, they look kind of, they look bad in general, like there might be some underlying disease process to it. I'm not sure. Or maybe it was edematous. I'm not sure.
Yeah, absolutely. It's a little bit, they're kind of a mess. I think you described it well. I mean, I think what I would point out is that, there's this density here, and then right next to it, there's kind of a hole, right? It's almost, and here's another one where it looks like there's a density, and then there's a hole right next door. It almost has like a little bit of a wall on it. So I think the radiologist would probably describe this as having both nodules and cysts. And that's a bit of a hint in the diagnosis.
Okay, nodules and cysts. Okay.
All right, so getting over to the pathology. Knowing you're on your phone, I'll make it as big as I can.
Okay, well, It looks abnormal. In the edges, I see more normal lung, but then in the center, there's like a proliferation of something. I see some pigment of some sorts. The interstitium is expanded. Yeah, there's not good alveoli, and then looks like there maybe, well, it looks like there's trying to form alveoli in some areas.
Yeah, there's a couple of residual gland spaces here.
Yeah, there's some glands, and then yeah, there's a lot of pigment in there, and there's also a lot of lymphocytic inflammation too.
Yeah.
I don't necessarily see any like overtly malignant cells or glands anywhere.
So probably not a carcinoma.
Yeah. So I guess there could be like some sort of stromal neoplasm or something.
Yeah. Any other lineages you'd think about?
Well, I mean, with all that pigment everywhere and the cells look loose, they don't look connected to each other. There's a multinucleated cell right there. I guess this could be like a histiocytic neoplasm.
Yeah, it's a good thought.
So I guess I could think, maybe this is stromal or is this hematopoietic?
Yeah, sounds reasonable. And then, so if you're in a thinking maybe it's a histiocytic process, and I'll tell you this patient has a fairly substantial smoking history, then does that narrow it down for you?
Oh, okay. Shoot, I know there's something I should know with a smoking history, but I can't remember what it is now.
Okay. And then how about this? Here's a couple of, I don't know what you can see on your phone, but there's a lot of cells that look like this. See this guy here? You see my arrow?
Eosinophils?
Yeah, there's a whole bunch of those guys.
Oh, okay. Well, there's eosinophils, and that also, I think, is more concordant with a histiocytic proliferation.
And which one? Which histiocytic proliferation?
Well, Langerhans cell has eosinophils, but isn't that typically in younger people?
Well, that's a great question. So I will tell you that Langerhans cell histiocytosis is exactly what this lesion is, and we think about more systemic forms of LCH in pediatric patients, but in patients who have a heavy smoking history, it's not an uncommon finding at all. And the interesting thing about smoking is that it looks like it induces these proliferations, and actually if you stop smoking, they'll actually regress spontaneously, at least in a subset of patients. So it's a really interesting biology again, of something that actually is a clonal neoplasm. And do you know what the most common mutation that we see in these lesions is?
VRAF V600E.
Yeah, exactly. And about half of patients who have adults onset smoking related pulmonary LCH will have a BRAF mutation. So it's very common both in the pediatric and the adult population. Any stains that you would like to use to just confirm the diagnosis?
You could do CD1A. You also could do S100. They both should be positive.
Yeah, absolutely. And they both will be. I'll just quickly show you. The stain we like to use is actually one called Langerhans. It actually highlights the Langerhans cells. It actually highlights the Birbeck granules within the Langerhans cells. So it's a very highly specific antibody. And this is what it would look like. This is actually our control slide, which is pretty similar to what we have in this particular case, but you can see that these lesions will have incredibly dense proliferations of these Langerhans cells. Here's just a higher power view of them. It's hard, I think, on the histology on this path presenter to see the individual Langerhans cells, but you can see that they're here admixed with these very dirty looking macrophages. So the dirty macrophages themselves are not the Langerhans cells, rather it's these sort of more subtle, almost sort of twisted histiocytes that are living there in the background. But a CD1A would give you a very similar appearance to this Langerhans IHC antibody. Just looking at these, if we look at the H&E, I'm a little hard pressed to tell you exactly which ones are Langerhans cells, but the guys that kind of look like this, if you can see my arrow, they're kind of elongated. They often can have a somewhat twisted, maybe one of these guys, sort of twisted nuclear contours. Those tend to be the Langerhans cells. The trick with this diagnosis is that these lesions can wane over time. Even if the patient continues to smoke, these individual lesions may scar down, and you lose the abundance of cells. You may only have a handful of eosinophils. You may not be able to see many Langerhans cells at all. And so that's kind of the sort of the scarred, the burnt out form of Langerhans cell histiocytosis. And sometimes somebody will have a suspected diagnosis of that, but you may just get the scarred or the burnt out version of it that you're trying to make a diagnosis on. And some pulmonary pathologists they'll say anything that looks like a really stellate or crab-like scar kind of out in the periphery involving an airway, especially if there's background emphysema, is likely to be burnt out Langerhans cell histiocytosis. But very nice job describing this case. Any questions about this one?
Is Langerhans a single analyte, a molecule?
Yeah, as in the protein against which the antibody's been brought up?
Yes.
You know, I don't actually know what part of the bird bed granule it's brought up against. I can certainly look into some of the literature there, but the specificity, we did a study that we published now about 15 years ago on it, and the specificity of Langerhans is really very high, much better than S100. But as is CD1A, I would say in our own experience, it's mostly our use of that is mostly from an aesthetic standpoint because it's just a very clean antibody relative to the CD1A stain. Okay, we have 2 cases left and we're definitely getting short on time. We can quickly go through both or we could just focus on one. Do you guys have any preferences?
I mean, I think we have time to go through the last 2 quickly.
Okay, we'll speed it up a bit. Anybody want to talk about case number 7 or slide 8 here?
I mean, if you need someone to, I can try. I don't know if I know what it is.
Do I have Brian or James?
James.
Okay, James. Okay, go right ahead.
Okay, so we have what appears to be another lung resection, wedge resection. We have another demarcated mass, which looks kind of nested and lobulated at this low power view. So as we're getting closer, what's really pops out is these cells are associated with necrosis. They look extremely pleomorphic, and they have kind of a cleared out cytoplasm in this nested configuration. And this kind of like fine septate between them. And yeah, a significant amount of atypia with a lot of pleomorphism. This is definitely a neoplasm. I would guess from how it looks, that's malignant.
Yeah. So what would you like to do with this thing? You want to stain it at all?
I think stain would be helpful, especially when we see a clear cell. I mean, I guess we would have to consider the possibility of a metastatic lesion like a renal primary, or maybe some kind of mesenchymal origin. But I'd start broadly because, I mean, generally speaking, I think it looks pretty epithelial, but I would stain with a keratin to make sure that's correct.
Okay. Okay, so it's keratin positive diffusely.
Okay. And again, we could rule out metastatic lesions, but as for primary lesions, I'm not really sure where to go down the IHC route with this. Very prominent mitotic activity too.
Yeah. So generally, you know, common things being common in the lung, and this actually kind of, it may or may not fall into the common category, but common things being common, we think of, is it a non-small cell or is it a small cell? And based on the morphology, you can probably rule out small cell
Right.
in that differential. So then within the non-small cell category, there's a couple of options. And what would those be?
Sure. So I've seen some suggestions of P40 in the chat, which would definitely make sense that this could be a really ugly squame.
Yeah.
That'd be a good start. TTF is a good option as well.
Yeah. I think that's great. I think that would be the perfect starting point, and you probably don't need much more than that. And actually, in my practice, I would probably forego the keratin. I would start in a case like this where I know there's a dominant, and I think in this case it was like a 7-centimeter lung mass. I know there's a dominant lung mass. Patient probably had a fairly significant smoking history. I would just start with the P40 and the TTF, and if one or the other of those is informative, then essentially you're done. So the differential is this a primary lung non-small cell that's either an adenocarcinoma or squamous cell carcinoma, or is it one that's undifferentiated, and you could consider it being a large cell carcinoma if neither of those markers is positive? Or you brought up the issue of the pleomorphism. One might argue that you could surpass the threshold of 10% giant cells in this case and actually call it a pleomorphic carcinoma. I think it's not quite pleomorphic for me. I would probably leave it as whatever the dominant sort of differentiation is with pleomorphic features or with giant cell features. But it really, I think, is important for us to understand what the sort of whether it's a squame or an adeno. And I would agree. I know it sounds like folks have said, oh, throw a P40 on it. I totally agree. I think there's a good chance that this is a pretty glycogenated looking squamous cell cancer. That said, I've gotten burned enough, or I've seen cases go down the tubes enough where an assumption is made when in the setting of a very poorly differentiated carcinoma, an assumption is made that it's a squame versus an adeno. And the reality is that solid subtype adenocarcinomas can very much mimic kind of the squamoid morphology that you see in a case like this. So I would probably just do the TTF and the P40 just to be absolutely certain of the differentiation state in this case. And if both of those are negative, as I've already alluded to, it would become a large cell carcinoma, which is a pretty unusual subtype of non-small cell lung cancer for two reasons. Number one, usually you're able to get a little bit of TTF or P40 out of most lung resection specimens like this that have some sort of inkling of differentiation. And secondly, you can only make the diagnosis of large cell carcinoma on a proper resection specimen. You're supposed to sample the whole thing and make sure that there's not a small component of better differentiated tumor in that lesion before you make the call of a large cell carcinoma. So we don't actually make that diagnosis very, very frequently. I'd say 1% or less of our non-small cell carcinoma diagnoses are now large cell carcinomas. I have to tell you, in this particular case, actually no stains were run. I pulled this out of the archive from maybe 5 years ago, and it was called the squamous cell carcinoma flat out. I think that's probably right, but I'm not totally sure. So this is a case that I would just go ahead and stain it just to be certain. And you know, the reason obviously is there's concerns around both choice of systemic therapy. It differs slightly. At this point, it's the sort of paired chemotherapy that you give with immunotherapy in the front line for non-small cell cancer is slightly different for an adeno versus a squame, so it will impact that choice of therapy. And then, of course, there's also going to be the interest in molecular profiling, which is much more of a significant issue in an adenocarcinoma than it is in a squamous cell cancer. So getting the diagnosis absolutely right, I think, is always a good idea, especially in a relatively undifferentiated lesion like this. I would err on the side of staining it to confirm. So that's the discussion around poorly differentiated tumors like this. And then the final case, which I think is just really nice because the radiology and the histology are kind of interesting to correlate, particularly, actually, let me pull it up from here so we get a little bit of a bigger image. Does anybody want to talk about this final case?
Let's see if there's anybody left.
Any residents left? It's just you and me, Eleanor.
I see Nina. I don't know. Nina, do you want to take this one?
Sure, I can. So I'm seeing the radiology, and there's this large, irregularly defined lesion. It looks like in the posterior of the lung.
Mm-hmm.
Here.
Anything you want to say about it? Anything that sort of
I'm not sure if it,
out at all?
I'm not sure if it looks like it's plural based or not. And then it has like sort of these I don't know, fluffy edges at the periphery.
Yeah, absolutely. It's definitely kind of fluffy around the edges. And then the other thing that's kind of interesting is that you can see these sort of linear sort of cleared out areas within it that are probably what they'd call air bronchograms. So you can actually see the bronchial tree kind of traversing through this thing, which would argue that it's not a completely solid mass, right? If it's totally solid, you shouldn't be able to see these air bronchograms. So there's probably more of a filling process as opposed to kind of a totally obliterative kind of replacement process, if that makes sense.
Okay.
So here is then pathology.
So here we have lung parenchyma. It looks like we have this sort of diffuse sort of lesion, or with ill-defined, I would guess, borders with the lung parenchyma.
Mm-hmm. And there's kind of a little bit more cellular areas over here, and then a little bit more open areas over here. I'm gonna go in.
Oh,
So is that loaded up for you now?
Yeah, so sorry, there was a lag. So it looks like there's these really abnormal cells that are lining these alveolar spaces, and some of them look to have mucin within them.
Mm-hmm.
To me, and they're sort of like sloughing off into the alveolar spaces. And it looks predominantly here sort of lipidic, like it's growing along these septi.
Yeah, absolutely.
So this looks to me like a mucinous adenocarcinoma.
Yeah, absolutely. So, you know, this is a really classic case, what we call an invasive mucinous adenocarcinoma of the lung. These are really classified as very separate entities from the rest of the kind of garden variety non-mucinous adenocarcinomas. They have this very characteristic pattern of spread, what we call this erogenous pattern of spread, where they kind of flick off spiral appearances and sort of settle down on different parts of the lung along the alveolar structures, and then begin to kind of proliferate in place. And they inevitably crank out just gobs and gobs of mucin, and a lot of that is what ends up filling these air spaces. And so again, instead of that sort of replacement or a mass that kind of replaces the normal structures, you just have this process of cells and mucin filling it. So it's more of a pneumonia, or they also call this like a mnemonic type of adenocarcinoma, because of the way it really just fills up the lung kind of from the inside. Do you know anything about the kind of genetics of these tumors?
No.
Yeah, no problem. They're pretty interesting in that these are tumors that you can see in smokers and non-smokers alike. The most common gene that's mutated in these tumors is KRAS, but interestingly, you're less likely to see kind of a smoking-related mutation in KRAS, and more likely to see that sort of pattern of KRAS mutations we maybe more commonly associate with gastroenteric type of tumors. And in fact, these tumors also tend to knock out their TTF1 expression, and in a subset of cases, they actually knock out the TTF1 expression probably at the genetic level. So you'll actually find loss of function mutations in the gene that encodes for TTF1, that's the NKX2-1 gene. So the kind of constellation of features you'll often see in these cases is a KRAS mutation that's not a typical smokers type of G to T transversion. You'll also see these NKX2-1 loss of function mutations. Sometimes you can see things like GNAS mutations just to further complicate the differential diagnosis with something like a metastatic pancreatic cancer, which can be very tricky to differentiate from these lesions, especially if you don't have a good radiographic and clinical history. Going kind of along with the fact that they knock out the TTF1, they seem to actually turn on more of a gastric protein type of phenotype. So often the mucins that you see in these tumor cells actually recapitulate the mucins you tend to see in the upper GI tract than those that you typically see in the lung. So really, again, very fascinating biology that kind of seems like it kind of goes back to the earlier sort of developmental phases of the lung in terms of the type of profile that it shows. And I think that's about it. Are there any other general questions I can answer before we finish up?
I don't see people raising hands, so it looks like.
I have a question.
Yeah.
Yeah.
So I was wondering, so we've heard that in the next WHO, there might be a new variant of micropapillary, like the filigree variant of micropapillary. Can you comment about, in your current practice, do you make that distinction?
Yeah, I don't distinguish it as a separate type of micropapillary. I recognize it as micropapillary, and I think that's kind of the key. I think it's just simply to recognize that pattern of growth in which you kind of have this continuous sort of stretch of tumor with a little sort of tufts, micropapillary tufts kind of coming out into the lumen. So I think larger structures rather than just these sort of individual air spaces with a couple of bunches of cells in them. I think the key really is to just recognize that this quote unquote filigree pattern as micropapillary and not as something else, and not necessarily to call it out as a filigree pattern specifically. I think that's kind of the gist with this sort of new description.
Thanks.
Does that make sense to you? Is that consistent with your impression, or?
Yeah, that was helpful. Thank you.
Okay.
Yeah, it's a Haldong. I have a question. So in general, about the airway spread out the tumor. So how do you deal with that in your guys' reports right now?
Oh yeah, so the questions are around STAS, spread of tumor through the air spaces. Yeah, so we have built it into our internal synoptic. It's currently an optional field for us, but I certainly like to encourage my fellows and my colleagues on the pulmonary service to actually comment on it. It remains controversial, but I really feel like the controversy around whether STAS is a real thing or not will probably diminish, particularly as the number of papers that are being published that comment on the prognostic importance of this finding just seem to continue to reinforce it as a poor prognostic feature, right? And it's been associated with different adverse outcomes, including local recurrence, including lymph node metastases, including distant metastases. And I think, you know, that's probably a function of the way a lot of the studies were designed, that they're looking at different different endpoints potentially like that. But you know, I think in general, there's so much data, and there's several meta-analyses now that suggest that indeed STAS is a real thing. It's not just an artifact, which of course is what the countervailing opinion is. That it's just a function of kind of the knife spreading the tumor through the airspace is not true spread. I mean, I have to say, you look at a case like what we're looking at right now, obviously lung cancers can spread through the air spaces because invasive mucinous adenocarcinomas have been doing it forever, right? We've recognized that as a feature of this particular tumor type, where they kind of lift off, they go somewhere else, they sit down, they create a new kind of population in that area. They can move across to the other side of the lungs and do it there as well. So they clearly have the capacity to move around and kind of settle down in different areas. And I think the non-mucinous tumors can do it as well. I do think we have to be careful in not overcalling it. And one of the kind of downsides, I think, of the classification schemas we have right now is that the criteria for calling STAS is not particularly well delineated. You know, there's been some papers that have suggested you need to be at least 2 air spaces away from the main tumor mass, or 3 air spaces away from the main tumor mass in order to actually call it as STAS. I don't know if that's going to be codified in the upcoming WHO. I don't think it will be. And we also don't really quantify it. That said, if I have a case on, you know, and the other issue is frozen section. Do you call STAS on frozen section, right? Because the clinicians are very interested in this now. The surgeons are very interested in it. It's, I think, a challenging call that said, there are cases that very occasionally come across the scope in the frozen section room where you see tumor everywhere, right? You see a discrete lesion on one side of the specimen, and then you see, as one of my fellows called this several years ago, tumor shower, right? You see these little flicks of tumor all over the place. Some of that certainly may be artifact, but you know, there's you know, I think our procedure is pretty good now, where we typically don't manage to spread tumor all over the place every time we cut a section of lung. So it can't all be artifact. And you only see that in very few cases. So I think when you do see that, it's probably a real phenomenon. I'm very concerned about local recurrence in those
only pressure will come because the adenocarcinoma is IQ. Then you have a couple of cells hang on surrounding that demarcation, the edge of alveolar spaces.
Yeah.
So you have a very big trouble actually.
Yeah, that's a challenging scenario.
Yeah. Okay, great.
Yep. Okay. Well, thanks for everybody who stayed on for so long and put up with the technical difficulties, including apparently somebody unplugging our internet. But thankfully, most of us are trapped at home and we can sort of, you know, do other things while we wait.
Well, thank you, Lynette. This was very helpful. This was a great session.
Well, thanks for the invitation to meet with you guys. I wish I could see you all in person, and I hope that I will.
Yeah. We'll try to get you back here into Seattle, maybe later this year or next year.
I hope so.
Thank you. See you soon.
Thank you.
Thanks,
Thank you. Bye.
Have a great night.
Thanks.
Thank you.